Welcome to MedMon Peja. My name is Benjamin, and today I'm going to talk about HIV, associated illnesses, as well as the opportunistic infections. So, in this video, I cover the associated illnesses or opportunistic infections in five systems. That's the gastrointestinal system, the central nervous system, the respiratory system, the cardiac system, the renal, and as a bonus, I talk about the AIDS-defining malignancies and some other common malignancies in people having AIDS that may not be as AIDS-defining. So in HIV, the gastrointestinal system is mostly going to be affected, starting from the mouth right to the anus. And when you look at the mouth of this patient, you may have oral lesions. And whenever we see oral lesions, we want to ask ourselves, can we scrape off those oral lesions? If it's a plaque, can we scrap it off? If it's scrapable, then that is most likely going to be candidiasis. And if it's non-scrapable, it's going to be orohairy leukoplakia. And this one is caused by the Epstein-Barr virus. And it's not a pre-malignant lesion. So most of the time, it's going to be harmless. And we shall just continue the antiretroviral therapy, and that may help to improve the outcome. Then we want to ask ourselves, is it ulcerative? If it is ulcerative, are they abscess ulcers? And these ones are going to be caused by the HSP virus. Then we move down to the esophagus. We can have a patient coming in with odynophagia, which is painful swallowing. And when we have faced with this, we want to treat empirically for candidiasis, and this is going to be esophageal candidiasis. If it is refractory, we want to scope for cytomegalovirus and herpes simplex virus. There could also be another cause of painful swallowing. Then we look at diarrhea. So when we have a patient having diarrhea, we're going to ask ourselves, is it more than 2 weeks or is it greater than 2 weeks? If it's less than 2 weeks, it is most likely going to be a bacteria, and it may be caused by the organisms that cause diarrhea in normal individuals. Then if it is more than 2 weeks, or if it is chronic, we are going to suspect some parasites that are specific to people in HIV/AIDS, and these are going to include Cryptosporidium, Isospora, Microsporidia, and we shall look at those ones in a moment. Then if we see bleeding or we have a colitis, we are going to suspect cytomegalovirus. We are going to suspect maybe they have a lymphoma or they are having Kaposi sarcoma. And remember, Kaposi is malignancy of blood vessels. So bleeding is not really a surprise here. Then whenever we have someone who is having wasting or hepatosplenomegaly, you want to make sure that their diarrhea is not coming from a TB or a Mycobacterium avium complex. And we specifically decide to look at diarrhea. So HIV-associated diarrhea is going to come. We're going to approach it in two ways. We're going to have the small bowel and the large bowel. So when we have a small bowel diarrhea, it's going to be watery and of large volume, and there's going to be diffuse cramping of the abdomen. But when we have a large bowel diarrhea, it's most times going to be bloody and it's going to be acute most of the time. So the chronic diarrhea in HIV is going to mostly be from the small bowel. It's going to be caused by the pathogens Cryptosporidium, Cystoisospora belli, and Microsporidia. And these ones are going to cause a watery diarrhea, which is usually afebrile. And whenever we see fever, it is important that you suspect or you find out if this person doesn't have a disseminated Mycobacterium avium complex. Then when we are treating this, for Cryptosporidium, we treat with a drug called nitazoxanide. For Cystoisospora belli, we treat with trimethoprim sulfamethoxazole. And for Microsporidia, we treat with albendazole. Some of the species of Microsporidia we treat with albendazole. Then we go to other causes of diarrhea in these patients, which are not the parasites. We have HIV enteropathy, and this one is going to come as a diagnosis of exclusion. After we have excluded that there is no other cause of the diarrhea, then you could come and say it is HIV enteropathy. Then we have those causing the large bowel diarrhea. So large bowel diarrhea, which can be bloody or acute in nature, is going to be mostly bacteria, and this is Campylobacter, this is Shigella, Salmonella, and you're going to treat with empiric antibiotics depending on your country's guidelines. Then we have the CMV colitis, cytomegalovirus colitis. This one we shall treat with ganciclovir and valganciclovir. Then we have disseminated Mycobacterium avium complex, which is watery diarrhea. And I told you, whenever we see fever coming in, weight loss, we suspect a MAC diarrhea. And this is, we're going to treat with azithromycin, clarithromycin, and ethambutol. So when we look at the CD4 counts of our patients, they can actually give us a picture of what could be actually going on. So if the CD4 count is less than 200, but greater than 100, we suspect most of the time is going to be Cryptosporidium or Cystospora. Then when it is less than 100, we suspect the Mycobacterium avium complex or the CMD. So from the GI system, we're going to look now at the central nervous system. And when we look at the central nervous system, I like to approach it in 4 ways. I want to look at features of acute meningitis, if they are present. I want to see if they have features of a focal brain lesion or a diffuse encephalopathy or a cognitive, which can also be paired with a cognitive decline. Then we want to see the spinal cord and peripheral nerve involvement. So when you look at acute meningitis or meningoencephalitis, the patient is going to come in with a fever, with headache, with neck stiffness, altered mental status, all the meningeal signs as we know them, the Cunnings, the Brudzinskis, and the organisms that we're going to query here, we're going to have the cryptococcus, we're going to have TB meningitis, we're going to have bacterial meningitis and viral meningitis. Then when you go to focal brain lesions, this means we have something, a focus somewhere in the brain. It most of the time going to come with headaches, seizures, and focal neurological deficits. And the most common causes of this are going to be toxoplasmosis, primary CNS lymphoma, tuberculoma, and bacterial abscess. Then we go to diffuse encephalopathy or cognitive decline. So in people who are going to come, they have maybe poor memory, they're having poor concentration, they're having personality changes. All of these coming when they have HIV, we have to consider that maybe they're having an HIV-associated neurocognitive disorder, which is called HAND, or they are having a progressive multifocal leukoencephalopathy, the PML. And this one we're going to look at it further in a short time. Then we have HIV encephalitis, which could also be causing this diffuse encephalopathy. Then the spinal cord or the peripheral nerve involvement. So we can have someone having a myelopathy, a radiculopathy, and a peripheral neuropathy. So a radiculopathy is a disruption of the nerve root, producing the symptoms. Then a myelopathy is actually affecting the spinal cord itself, producing symptoms. Then a peripheral neuropathy, of course, is affecting the peripheral nerves themselves. So some of the things that we're going to have is a CMV radiculopathy from cytomegalovirus. We can have HIV-associated myelopathy, and then we have drug-induced neuropathy causing the peripheral neuropathy. So when you look at the progressive multifocal leukoencephalopathy, this one's going to come as a result of activation of the Josi virus after immunosuppression. This is most likely when a patient has a CD4 count of less than 200. And clinically, it's going to come up as some subacute focal neurological deficits, as well as cognitive decline, hemiparesis, and visual changes. And when we do the diagnosis, to do the diagnosis, we shall need to do an MRI, where we shall see non-enhancing white matter lesions. And when we do the CSF, we may actually find the Josi virus itself when we do a PCR from the CSF. Then the other test that can be done is the biopsy, but the biopsy is no longer being done commonly. So the gold standard we are doing here is going to be the CSF PCR for Josi virus. And the treatment is not going to be specific, but we may try to give the antiretroviral therapy to see if the immunity goes up. We have a halting of the progression of this disease, but normally and almost all the time, the prognosis is going to be very, very, very poor. Then we have toxoplasmosis. Now, toxoplasmosis is going to come as a result also of reactivation, and this is going to happen when the CD4 count is actually less than 100. And toxoplasmosis is going to be caused by Toxoplasma gondii, which is got from maybe the litter of cat or from kittens. So these people will come in with focal neurological deficits, seizures, confusions, and also headaches. And for us to do this diagnosis, when we do the MRI or the CT, we have multiple ring enhancing lesions. And this could be in the basal ganglia, this could be in the corticomedullary junction. And when we do also a serological test, we can actually see that we can have a positive test for this. And Normally, in limited resource settings where we do not have the luxury of doing these tests like the MRI, you may decide to do empiric treatment, whereby we treat with pyrimethamine, sulfadiazine, and leucovorin, which is also called folinic acid. And folinic acid is a derivative of folic acid. And the folinic acid is mainly there to help prevent the suppression of the bone marrow. Then the prognosis. So for someone who has had toxoplasma, or if someone gets a CD4 count less than 100, normally we give prophylaxis for this, and we shall give trimethoprim sulfamethoxazole, TMP SMX. We are going to give this for prophylaxis of these patients. Then the prognosis is good if we treat early, and if we delay the treatment, the prognosis is actually going to worsen. So when we go to the respiratory system, most of the times, the most common presentation are going to be bacterial pneumonia, pulmonary TB, and PCP. So bacterial pneumonia is going to come when you have any CD4 count. Even when you have greater than 500, you can still get bacterial pneumonia in someone with HIV. Pulmonary TB is also going to come at any CD4 count, and it's going to be atypical if it comes with the CD4 count is less than 200. It's going to be even worse. Then the PCP or the PJB is going to come normally when we have a CD4 count of less than 200. So the key features in bacterial pneumonia is that we are going to have an acute fever, we are going to have a productive cough, we're going to have a pleuritic pain and a lobar consolidation on chest X-ray. Unlike that, when we look at the one for PJP, it's going to be subacute, it's going to be a dry cough, it's going to have dyspnea, the patient is going to have dyspnea and hypoxemia and diffuse infiltrates when we do this chest X-ray. Then when we look at pulmonary TB, the cough is going to be greater than 2 weeks. We're going to have fever, weight loss, night sweats, which are the TB symptoms. So the diagnosis, when you're diagnosing a pneumonia, we're going to do a chest X-ray, we are going to do a sputum culture, and that will be the gold standard. Patients with HIV that have TB, we are going to do a gene expert, we are going to do a culture. These are going to be the gold standard. And then we can do a smear for acid-fast bacilli, we can do still a chest X-ray, and now they have introduced the urine LAM test. So when we come to PGAP, the gold standard test is going to be the bronchoalveolar lavage, which we shall do with a silver stain. And that is the gold standard. Then we can also do a chest X-ray, which is said we shall see diffuse infiltrates, unlike in a pneumonia where we see a lobar consolidation. And for TB, we see cavities or we can see miliary picture. So when it comes to the treatment of pneumonia, we're going to use mostly ceftriaxone and azithromycin. For TB, we are going to use the RIPE regimen, or you can actually follow the different guidelines depending on your country. Then for PJP, most times we use trimethoprim sulfamethoxazole for 21 days. And whenever we have a patient who has hypoxemia, we try to introduce a steroid until that improves. Someone with respiratory problems or someone with times we have other things that could be going on in the lungs that could actually cause this, and one is that we have fungal infections like histoplasmosis, coccidioidomycosis, aspergillomas, invasive aspergillosis. Then we have viral infections like HSV, CMV. We can have Kaposi sarcoma also having pulmonary manifestations. We can have non-infectious complications. We can have HIV-associated pulmonary hypertension. We can have drug-induced lung disease, lymphocytic interstitial pneumonitis. We can have the pleural disease from TB, from bacterial empyema from that pneumonia. Then we can have Kaposi sarcoma effusion. Then others, we can have bronchiectasis, we can have pneumothorax, and we can have pulmonary embolism. And these ones are always just going to come from complications of either pre-existing diseases. So when we go to HIV-associated cardiac problems, what happens is that most of the times the most common is going to be cardiomyopathy, and it's going to look like the dilated cardiomyopathy. Then they will get into heart failure, and it is suspected that this cardiomyopathy is probably due to HIV itself or other infections that come in, as well as the antiretroviral therapy could be a cause of that cardiomyopathy. Then we have pericardial disease, which include pericardial effusions, and these ones are going to be often due to the tuberculosis. Then we have pulmonary hypertension, which is going to come due to chronic inflammation that leads to right heart strain. Then we have endocarditis, which is increased in IV drug users. Then we have accelerated coronary artery disease, and this is because in HIV there is an increased atherosclerosis due to the systemic inflammation or the metabolic effects of the antiretroviral therapy. Then we have the HIV-associated renal problems, and these are going to include the HIV-associated nephropathy, where we shall have a focal segmental glomerulosclerosis leading to proteinuria, and we get a rapid CKD, and this is going to be more common in Black. So apart from HIV-associated nephropathy, we can have immune complex kidney disease, and where we shall get a glomerulonephritis coming because of HIV immune complexes. Then we have the medication-related nephrotoxicity, that is if someone is on tenofovir and indinavir, then this can cause tubular injury. Then others, we can have acute kidney injury from infections, dehydration, and sepsis. So we have the age-defining malignancies. The age-defining malignancies, the first one we have is Kaposi sarcoma, and this one is going to appear as purple red lesions that are going to be in the skin, the oral cavity, or in the GI system actually when you do endoscopy. Then we have cervical cancer. It is also an age-defining malignancy, and you have the non-Hodgkin's lymphoma, which is mostly aggressive and often extranodal. So these usually occur at CD4s that are less than 200, and initiation of antiretroviral therapy sometimes reduces the risk of us getting these malignancies, as well as improving the outcomes of a patient. Then we have an age-defining malignancies but are also common in HIV, and that is the Hodgkin's lymphoma by Epstein-Barr virus, and it's going to present with the B symptoms. We have anal cancer in men who have sex with men. Then we have lung cancer as well as liver cancer. So we have come to the end of this video, and if this video has helped you, if you have learned something, or if you feel like this is a useful video, I would appreciate if you leave a like, a comment, or you subscribe to the channel, as well as share this video with a friend. Thank you very much. This is Mid One Pager. My name is Benjamin, and have a nice day.